we sent you two surveys that it was good because 99% of you answered the survey. That is very unusual. Then I'm going to tell you what are the results of the survey. And the first question was, are you using or you are recommending steroids in your patient with pneumonia? And it was, again, these are the results. 60% say yes, 40% say no. Then we're discussing with Pierre that changing practice takes time. and we still have 40% of this group. Now, there's no excuse in this group that we have not read the article. I mean, we all read the article, but still even reading the article, 40% still say no steroids. But the people that say yes, these were, and it seems to be that everybody says severe community acquired pneumonia with an inflammatory response, severe community acquired pneumonia, not immunocompromised, high inflammatory markers. The stories tend to be repeated. CAP in the ICU, CRP more than 150. We know who provides the answer, the person that did the study, the Barcelona answer. Severe CAP, we have inflammation. Those meeting criteria of the Queen et al. To someone, this is the answer. One of the Pierre, was this you voting for yourself? Someone just follow your criteria. Yes. Yeah, 60%, yes, half and half. Yes, you're right. Then this was the results of the steroid survey. Okay, and the other question was artificial intelligence in medicine. And then there was two questions. One was, are you using artificial intelligence, primarily not ChatGPT, that is what we were discussing, in your regular life, or you're using in your practice, in some form of medicine involvement. And here, 60% are not using anything, 15% for personal use, and 25% for personal and professional use. And this was, and when people are using at this moment, writing summaries of data, production of summary document for research. One answer was for research purpose, we couldn't figure out. Editing manuscript, prepare presentations. These are the uses at this moment. But we were discussing previously that when I survey the residents or some medical students, the use is close to 100%. Then to me, this group here, only 25%, is to me demonstrated that we are far away from the medical students and the residents. But and then I want to present on this topic. This is a case report that we just published in our local journal. that essentially, let me tell you what was the story here. This was a patient with non-resolving pneumonia that a pulmonary group did the consultation. Then in the words consult pulmonary, the pulmonary attendant did the consultation, and then the person in the evening went and present to ChatGPT the clinical case. And ChatGPT gave recommendations. Next day, go to the hospital, see the patient, figure out what happened, and then at the end of the day, present the patient to ChatGPT, ChatGPT give recommendation. There for a couple of days. This is, for instance, these were the first recommendations that were coming from ChatGPT, said, reevaluate diagnosis, maybe fungal mycobacteria, look for resistant bacteria, assess for underlying conditions, pulmonary embolism, order a bronchoalveolar lavage. And I have to tell you that these were all pulmonary recommendations. Then we figure out the 31 recommendations from ChatGPT, present the case and the recommendations to another pulmonary physician to evaluate how many of these 31 recommendations were very appropriate, or inappropriate, or may harm the patient. And the answer is that essentially they were all very appropriate or appropriate. There was no recommendation from these other pulmonary physicians that didn't know that this was ChatGPT. There was no recommendation that the pulmonary physician considered was inappropriate or may harm the patient. Then again, it's one case report, and we see the literature, these things are coming more and more, and probably we're discussing, we need to move from case report to a little more elaborated. I'm sure there's going to be a lot of clinical studies moving forward in this topic. Then these two topics are open for discussion. Steroids in community-acquired pneumonia, yes, no, when, what happened with the clinical practice. And the other topic for discussion is how do we see artificial intelligence moving into clinical practice, and how do we, any considerations or any discussion? Okay.
Can I say something about AI?
Yes, of course.
Well, one of my favorite anthropologists who talks about this would say it's neither artificial nor intelligent. And we should really know that it's just statistical learning of large data sets.
Yeah.
And those large data sets represent a corpus of knowledge that's just captured in the internet. And it does seem like it's really a powerful way to kind of consolidate some of that collective knowledge. The danger is that it just learns from what it sees. And so if our collective knowledge is biased, of course, the statistical learning will be biased too. So we have to just be careful.
No, this is, agree, there is a lot of articles indicating bias, but it's interesting, as we recognize that we have biases and the machine has biases also. No, I agree, this data. But how do you, I mean, you are in the hospital every day, you have your residents, your medical students. What is the discussion with the residents and medical? Because again, this is the collective information in the internet, and the collective information in Google, and in essentially everything that is free, because you cannot get into anything that you have to pay. Then you get for what you pay. This is free. But we were completely surprised with this case, that even with information that is in Wikipedia, you can still, because probably everything is coming from Wikipedia or some free articles in Google. And we still are, or probably it's also, all the guidelines are open access, all the guidelines in medicine. There is a lot of things that are open access. Of course, the ChatGPT cannot get into a New England Journal of Medicine or JAMA because you have to pay. But everything that is open access is already there.
And you can ask to the ChatGPT from the sources of the information, because maybe if you ask the sources, the ChatGPT is going to tell you one paper from JAMA, one paper from CHEST, one paper for...
The only references that these programs are giving you are free references. It cannot give you JAMA because you cannot read JAMA. Because read everything that is free.
Maybe the abstracts, I don't know.
No, well, no, you're right. The abstract would be, at the beginning, there was an issue, what we call hallucinations, and the references were, a lot of references were wrong. But then recently, we've been asking, and the question is, give me the reference without hallucination. No, this is what we write. If you write, give me the references without hallucination, give you the right reference. Because we've been checking the reference from ChatGPT, go to PubMed, and we find now all the, at the beginning, we checked the reference, went to PubMed, and they were, at the beginning, ChatGPT will know that your name is associated with cardiovascular events, and cardiovascular events are a lot of publications in chest, and they will come out with your name, chest, and something and generate a reference. But now this is hallucination. But now it's very important to ask the right question. But now we are getting the proper references.
How do you address the issue of whether there's an art in medicine anymore, or is it all purely regurgitating facts and synthesizing them? In other words, if you personally evaluate a patient, do you get the same impression as if somebody sent you all the information and you sat at home and manipulated a computer? Very hard to say, but I think that the premise of AI is that there's no individual interpersonal evaluation that plays a role at all.
No, and I would agree. I say that at this moment, at least in my discussion with the ID fellows, I mentioned, to me, this emphasized more and more that I've been saying in my teachings that the primary role of the ID fellow is figure out what chapter of the book you need to open. The chapter of pneumonia, once you figure out the chapter, then you just go and read. But the difficult part is figure out what chapter you're supposed to open. To me, this is still the art. You need to figure out what's wrong with the patient. But once you figure out what's wrong, I can tell you that probably once you figure out the proper question, the question you just type not even type the question.
But
you're
I think
going to ask the computer, okay, this is a 60-year-old with community-acquired pneumonia with COPD. What antibiotics? I send the patient home, and because it's going to be on. The computer is going to tell you send it with doxycycline, or the computer is going to say, is the person pregnant? No, they just say no, it's not pregnant. Again, you're going to have a dialogue, and
right.
but the first part, I think that I want to believe that the figure out what's wrong with the patient is not going to be the machine.
This was in some ways the discussion years ago about guidelines. Did you need, in other words, should we as a group, maybe we should sit down with a computer and write guidelines for obstetrics? I mean, why do we need to know the field if we can gather all the data? In other words, do we need experts to write pneumonia guidelines, or could we go get, I don't know, lawyers to write pneumonia guidelines, because they could access the same literature that we could, and they could get the same meta-analyses. So, I guess the question is there an intangible input of an expert that would be hard to quantitate and describe and equate with AI?
No, and I think that to me, these are going to be the studies that to me are going to be designed in the next couple of years. The studies, because we're discussing the fact that the New England Journal of Medicine is open, is not going to be a section of artificial intelligence, it's open a journal of artificial intelligence, and people are discussing this type of thing. Then these are going to be clinical trials of not just based on clinical trials to define outcomes. But I think at this moment, I may say that the initial assessment of the patient is supposed to be the physician. After the assessment, I'm sitting in the conference, we have patient management conference, and we all know how you treat this. I'm thinking, why are we asking? What is the dose of amphotericin for this patient with mucormycosis? I mean, this is, I don't need to remember this anymore, these type of things. To me, the question is that the patient has mucormycosis. What do you think? And once you know what the patient may have, the rest.
It's useful if you have an answer, but there are a lot of diseases where there isn't one right answer, or there aren't any right answers, and you have to. And if you're going to, for example, be treating a multi-drug resistant Acinetobacter, or you're going to be treating a pan-resistant mycobacteria, how do you ask a computer what to do?
Again, this case was a case that this patient was not responding to antibiotics, was 10 days of an infiltrate, and the pulmonary physician went there and said, it's funny because he said, this may be a mycobacterium. But again, went through the idea of non-resolving pneumonia, and ChatGPT was given exactly the same things. I don't know how to explain it, but
It's very clear, if there's a body of knowledge that you're going to repeat or a computer can repeat, it should be the same. But if there's judgment involved where the body of knowledge doesn't give you an exact answer and you have to use your judgment about which knowledge is most important, that's very confusing.
I think that sometimes, at least when I'm in rounds, and you get 3, 4 people, sometimes you're discussing a differential diagnosis. Someone says, and a student may say, why I didn't think about this? Because it was escaped to you. Now you can ask and say, okay, this is the list. That you remember all these things? It's almost like a support. It's a support system that you are going to be talking and giving you the answer, or just giving the list. As a support system, I think it's coming. Now, the question is going to be with medical students and with residents, are they going to stop thinking and just looking at the machine? This is, because now we already are set on having the art and try to make a clinical judgment. Any other? Yes.
Yeah, no, this is interesting to us, a physician at the program, but also 100%. And then on the up-to-date side, in some sense, a little bit of an existential threat to us to create content. And, we've been thinking about how if we employ this and how we might employ this. Saying that one thing powerful user experience time. Look at how users you can watch look directly at a right answer, still get the answer to the question. So as we're thinking about it, we're thinking about more on the end of accountability.
Any consideration? Oh, no. Yes, I know. The consideration is that Sheila mentioned that from up-to-date perspective, there is a discussion on should we incorporate artificial intelligence and how this is going to, because it's interesting that people look for the answer, the primary care, the busy physician in the clinic, not the specialist that you go and try to figure out. The busy physician in the clinic try to get the answer. Give me the answer, see what I need to do. And how this may be something that may even facilitate this, reaching this answer faster. With the understanding that you are assuming that the answer is not going to be coming from the internet, it's going to be coming from up to date.
Assuming that one can limit one resource.
Yeah, assuming that all of a sudden, up to date is going to be based, is going to have an artificial intelligence program that is going to, you don't need to go to up to date and figure out the topic. You just can ask up to date and tell you the answer based on your question. Any comments, or they cannot even digest this is
I'd saved this article, but there was years ago in the Pharos, which is the AOA
yes.
journal, there was an article written by a guy from Duke who went to the ward to become a ward attending, and the medical students told him, basically, we don't want to hear what you have to say. We have up to date. And he said, I want to be out of date. I want to be able to use my years of experience. I want to be out of date, not up to date. And I would like to. And I guess the question is experience going to matter for anything? Maybe not.
Could I
Well-
argue that the knowledge that comes from the internet and ChatGPT is actually experience?
When you sit or I sit with a patient, you get I think, I mean, you get a sort of subliminal assessment of that patient that would be very difficult to describe and put in writing. And when you're taking a history from someone, which is what you would feed a computer, that's very subjective as to how you interpret what they've told you and what it means to you compared to someone else who took that same history, or if they would ask the same questions.
I completely agree. And that's the human contribution. So I really think, the model of human computer interaction is not when, and how and where do computers replace humans. It's really how do computers augment human capacity? So our capacity is not math.
No,
And our
no,
capacity is not remembering doses of antibiotics, but our capacity is actually to develop therapeutic relationships with patients and get the story and to try to direct all of the potential very harmful diagnostic tests, procedures, and treatments that we have available to us to try to be strategic and actually help a patient in an empathetic way through an episode of illness. And so what to me, the ultimate computer role is to help me offload cognitively so that I don't have to remember the antibiotic dose, but I
Right.
can stay with the patient. The problem is that technology is not really designed to get us back to the bedside. It's actually designed, unfortunately, by a lot of industry that wants us to engage more and more with the computer. So unfortunately, what we see is we're spending more time with our computer and less with our patients. And that really is something that, HCI that's really optimal needs to be the opposite. It should allow us to spend more time with our patients and less time with the computer.
Okay, sounds good.
Okay.
No, this is, no, this is exactly the point. Now, I've been talking to some internists in Louisville, and they're waiting to exactly what you just mentioned. They're waiting for artificial intelligence to download from them all the connection with the computer and all the things, all the back and forth that they have to do. And even the connection with the patient through the portal with the patient. They want artificial intelligence to send information, to send the patient education. And the idea would be they will have to have more time to be with the patient face to face. Now, we'll see what happens. But a lot of things that because it's almost, Mike, it's almost like you are talking about the person that's going to do the consultation when nobody knows what's going on with the patient. But really the hospital is, and the internist, a lot of the things that happen in primary care and at the hospital level is all very, very automatic. I wonder how much of what you're just saying is happening in.
No, I'm just
the busy
reflecting.
clinic.
I mean, I remember, if you think back to the 200 years ago, before we had any medical advances, doctors were still thought to be valuable because they could console patients, they could talk to them, they could get them through difficult times through empathy or whatever. I think maybe that's going to be our new role. We're not going to be needed anymore for our knowledge or for our diagnostic skills. We're going to be there to hold hands again, and the computer will do all the rest. So it's going to be back to how it was. I mean, in an odd way. I mean, with all the advances, we may be reduced to the sort of supportive role that doctors played before there was any of the therapies we have today. You know what, we should have a mic.
Let me give you,
I mean, I hope,
know how is the medical brain developed? You know what I mean? I don't know. I don't know the answer to this question.
So one other thought, and I don't know the answer for sure to this. What should medical school look like in 20 years? You know, what should we, I mean, do we need medical school, or do we just teach you how to use a computer?
Well, at this moment, yes.
Yeah, I'm not going to answer that question, but I want to buttress Sophie's point. I saw a video of somebody who fell. Somebody fell down, needed help. You know what people did? They took out their phones and they were taking the picture of that person. And you're going to go like, what is wrong with people these days? All you care about is taking pictures so you can post it on Facebook. So there's no empathy, because if you don't really think about what you're doing, really, you're not going to empathize with anyone. And at that point in time, your own social media stuff is stuck in your head, and you don't know to throw everything out and rush and help that person that's in need. I'm sorry, I'm very emotional about it, because it just makes no sense. And she's right, but thank God most of us will be gone or retired by then.
So regarding the question whether we need human beings for empathy, and whether they are better than GPT-4, there was a paper out, I think 4 weeks ago or so. I think it was in Lancet. And what they did was there were questions asked to general practitioners via email, and they were answered via email. And then they took these questions and gave them to GPT-4, and the answers of these questions were then evaluated. And what came out was that they were from the content better, and they were better from the empathy, which may be because you usually don't have much time for answering all these questions that people ask you. And so you lose empathy. But time is not an issue for a computer, right? The computer has endless time. And so I think there is a lot of potential for GPT-4 to help us in providing good care for our patients. I think when it comes to very rare differential diagnosis, GPT-4 may well outcompete myself. When it comes to first diagnosis in the ER, GPT-4 may outcompete young doctors. But where I see a problem is, for example, I recently saw a patient. He told me, he was an academic, and he told me that he lost weight on intention. And you know, what you said, I didn't believe him. And so I asked his wife, was that really on intention? In the end, he had cancer. So I think it's this nonverbal problem. If you ask GPT-4, the patient lost weight on intention, GPT-4 definitely say, well, that is, I do not have to consider that anymore.
So what should medical school look like in the future?
Good question, but I think definitely it should teach the students how to deal with this kind of information that may well help, but may also well be misleading.
I think
That's
that,
like with all what you see in the internet, right? I mean, this information can well be helpful, but it can also well be misleading.
it's interesting because you mentioned this, and in my discussion, one internist in Leuven mentioned that he would like artificial intelligence to send the email back whenever he have a question of the patient, to send the email back to the patient. Because he has to go home and start answering all the emails from the patient. And it's fine because I remember there's more empathy because you have the proper wording with ChatGPT that, I mean, this is, but I think that the answer a little bit, again, I don't know what is the answer, but I think that definitely is going to be artificial intelligence. And, you know, I mean, I learned from these two guys that are working with me, Stephen and Thomas, that are, but I think that large language models, and this time, it has to be a class in medicine, because you need to learn how these things work and how you're going to apply. And it has to be a class. It's going to be more, I don't know if it's going to be more important anatomy, but it's going to be very important for the medical students to understand large language models or whatever other system is coming. Because this is going to be, but on the other hand, it's going to be, as you say, sent at the internet. By the time that they go to medical school, they are going to have so much interaction with these models. Any other general comments? Yeah. Yes. 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 Okay, well, for the survivors, we're going to have dinner. It was at this time they put the ATS, the infectious disease assembly was at this time. Then everybody went to the assembly. I mean, in reality, we were all supposed to be there, but some decided to stay here. It's good. Thank you. Thank you. Oh, thank you. Thank you. Yes.